Good afternoon. Can everyone hear me okay? My name is Phil Murray. I'm a consultant in paediatric endocrinology from Manchester Children's Hospital. I've done many talks to a lot of health professionals, but I hope you forgive me. This is my first time speaking at any form of family conference or parent event, so please do be kind. And if anyone has any questions at any part throughout the presentation, just wave a hand. I'd be delighted to answer. So we're going to cover a few different topics, all surrounding Costello syndrome and some of the hormone problems that we can see. So I'm going to talk firstly about growth, about normal growth, and how we might approach managing children who have short stature. We're going to talk a bit about puberty, what is normal puberty, and how we might manage either an early puberty or a late puberty. We're going to talk around blood sugar problems, and then lastly, we're going to talk about calcium problems, specifically about hypercalcemia or high levels of calcium. So normal growth has at least 3 distinct phases. So the first phase is from the time when you're born up until around 1 year of age, and that's the infancy phase of growth. And during that time, growth is mainly dependent upon nutrition. As you move from 1 year of age through childhood, so all the way up until around the start of puberty, you enter this rather slow phase of growth. And at that point, growth is actually mainly dependent on hormones, specifically thyroid hormone and growth hormone. So where we see children have a problem with either the thyroid hormone system or the growth hormone system, what we see is they do relatively well for about the first year of life, and then after the first year of life, the growth begins to tail off. Once you hit any time really from the age of 8 onwards in girls, 9 onwards in boys, you can have puberty starting, and puberty creates this second increase in growth. Now, again, where we see a problem with puberty, what you see is growth does quite well until around that time, and then it begins to tail off. So the timing of when we see changes in growth can tell us a great deal about whether the problem is likely to be with nutrition, it's likely to be with hormones, growth hormone, or it's likely to be to do with puberty. One of the key tests you might see here a lot of doctors looking at is a test called a bone age. And it's important to say that you finish your growth when your bones reach the age of around 15 in girls or 17 in boys. And the age at which the age of your bones can be different to your chronological age. So your bones may look older than you are, or they may look younger than you are. So if your bone age is advanced, your bone age is 14 when you are 12, you're going to finish growing a bit sooner. And equally, if your bone age is younger than you are, so you may be 7 or 8 and your bone age is 5, then that tells us you're going to have a few more extra years of growing before you finish. So commonly ourselves, when we're plotting children on charts, we plot where they are for their current height, and then we look to see where actually would they be for the age of their bones. And if we see that their height is doing not bad for the age of your bones, then we know in the end, when you reach your final height, you're probably going to be okay. And if you see a delayed bone age, it tells us that there may well be a hormone problem, but it could also be caused by a large number of other issues. So what do we mean when we talk about short stature? Well, there are largely 2 things that we're looking at. Firstly, we're looking to see, is the child shorter than they should be for the normal population? So we'd use a definition for height of, we'd use less than the 0.4th percentile. So on the chart, I'm sure many of you will have seen these, the main line in the middle represents the 50th percentile, and the very bottom line represents the 0.4th percentile. And we'd be interested in investigating why any child is shorter than that. We also look at how tall the parents are. So largely height and growth is something which is genetically determined. So if you have 2 very tall parents, if both of your parents are up at the top end of the chart, and actually you're in the normal range but down at the bottom, that might still represent a problem. And equally, if you have 2 very short parents, so they are right down at the bottom end of the chart, and you're also at the bottom end of the chart, that's probably not going to represent any significant problem with the child's growth. They're just reflecting the parents' growth patterns. We also look at growth velocity, so how fast is a child growing? And again, if you see a child who's growing along their own line, but they're not falling away or falling down from that line, that's more reassuring that their health is good. Where we see someone, in actual fact, who starts out, say, on the 50th percentile and then drifts down to the 25th or lower, that would again be indicative of a significant problem going on. So there are lots of different causes for a child to be born to grow poorly. One common cause is what we call constitutional short stature, and that really just means that the child is growing at a slower pace than most other children for their age. And children with constitutional tall stature will have that delayed bone age, and when they get to 15 or 16, they will often keep on growing and they will actually catch up and do better. There are many genetic causes for children to grow poorly. Children who are born small in the first instance, so if you're born small, around 10 to 20% will never catch up with their growth and will need some extra help. Lack of nutrition and chronic illness will all cause poor growth. We also say that you can get poor growth because of psychosocial deprivation. You can get problems with the bones themselves, so with conditions we term skeletal dysplasias. And there are recognised conditions which cause short stature, and that's where Costello syndrome would come in, along with other similar conditions like Noonan's. In the past, there used to be a large number of children who had short stature, and we thought they had a genetic condition, but we couldn't tell which. That those children are becoming rarer and rarer with the advent of all the new, fancier genetic testing and the better skills of our clinical geneticists. The photograph you can see it'll be on your right hand side, is of two twins, and they were born exactly the same size, and then around 8 years of age, they were looking markedly different. And so one was much shorter. You can see he was, on the centile chart, he was well below the bottom. And that's a very classical pattern of something we recognise called growth hormone deficiency. So he'd fallen off with his growth. He was very much shorter than he should be. And what I want to highlight here is where we give growth hormone to a child who has low levels of growth hormone. You can see a really quite dramatic improvement in height. And a proportion of children with Costello syndrome who are short will also have low levels of growth hormone. And if you have low levels of growth hormone, we can see quite a good response to treatment with recombinant human growth hormone. You've probably all seen many slides like this of the RAS-RAF MAP kinase. I don't think I'll spend much time on that. But obviously Costello syndrome, like Noonan syndrome, and a great many other short stature conditions has changes in the genes involved in this pathway. And that's a very important growth pathway within the cells themselves. So where we come around to look to test someone to see if they have a hormone deficiency, we'll often start with a simple blood test. And the simple blood test will look at hormones like thyroid hormone. And if you're lacking in thyroid hormone, that's a very easy condition to treat. I just give a patient a tablet with some thyroid hormone in it. You take that every day and that will resolve that problem. Where we're looking at growth hormone and growth, we start out by looking at in the blood at levels of proteins called IGF-1 and IGF-BP3. So your brain makes growth hormone, but it makes it overnight. So it's very difficult for us in clinic to measure growth hormone levels. So we look at these other molecules, IGF-1 and IGF-BP3, which reflect the body's production of growth hormone. And if they are low, it gives us an idea that that's where the problem is likely to lie. There are other hormones made in the brain that we look at as well, cortisol and some of the puberty and sex hormones. But in essence, if we think looking at growth and looking at the levels of these levels, IGF-1 and IGF-BP3, that there's likely to be a problem with the growth hormone, we have to go on and do an extra test to look at those growth hormone levels. Now, I said your body doesn't make growth hormone during the day, and so we therefore, when we want to test, need to give children an injection to stimulate their body to make growth hormone. And there are very many different ways in which we can do that, but essentially all the tests involve the child being fasted, having a drip put in the back of the hand. You give an injection into that. Commonly it uses things like arginine or glucagon, and that pushes the body's growth hormone levels up. And then we measure over about 10 blood tests after that how much growth hormone there is in the body. We've got work going on to try and simplify that and make that into a single test, but a single blood test, but at the moment that isn't quite there. The tests for puberty hormones are relatively simpler. It's a similar process of a drip, an injection, but the number of blood tests after are very much lower. But you can see from the fact that we need a cannula and many blood tests, We only want to do growth hormone tests where we think there is value in doing so, and it's not something we do in everyone we see on the first occasion. So where you're looking at the standard growth charts is never going to be particularly helpful for children who already have a condition which is predisposing them to grow poorly. It's much more important, I think, to look at the individual growth trajectories. So again, if you see a child growing along their own line, where they're growing up quite nicely, but below that line, we would worry less of. If you've got a very flat growth curve and it's falling further and further away, then that's something which would worry us more. Again, where we think about children that we give growth hormone to, what we're looking to see is that after, I don't know how well this projects, but essentially you're growing along, and after we give growth hormone, what we're really looking to see is that you begin to accelerate up the chart. It takes about a year after we start anyone on treatment before we can tell whether that treatment is working or not. And we really need to see their height beginning to accelerate up, to at least perhaps not through the centiles, but further towards that 0.4th percentile. And if after a year of treatment you saw that it was making no difference to the height and no difference in anything else like muscle strength, then actually you need to think about stopping it after a year. Growth is a very slow process, so actually I don't feel that we can really assess things with less than at least 1 year of treatment. Just to mention that, I'm sure many of you will be aware, there are specific normal growth charts for individuals with Costello syndrome for both males and females, and it's for patients who have not been treated with any form of growth promoting treatment. So that it's quite useful again, and particularly if you see a child falling through those centiles, falling down, that would mean we should be looking very hard to make sure there's no other medical problem going on. And also if you see a child who is actually off the bottom end of the chart for Costello syndrome, again, we need to be looking very hard to be sure there's no other medical problem there. This is just some data taken from a publication on using growth hormone therapy in Costello syndrome. So this is 2 different patients. Again, here you can see a child beginning to fall off the centile after the age of 1. So again, that's a reasonable indication that there might be a problem with that child's growth hormone levels. They started in growth hormone, again, about the age of 7. And over time, you can begin to see we slowly get an improvement, and actually where we end up with is a height which is pretty much the same as the mean parental height. And the mean parental height is where we should be based upon mum and dad's height. The second child he treated again about the age of 7, and you can see this child similarly falls off with their height after about the age of 1 to 2, and perhaps you can see it takes a few years before we begin to see an improvement in growth hormone therapy, improvement in height using growth hormone treatment. It takes quite a while before we see some good movement up the chart. Often when you look at growth velocity and you look at how many centimetres per year they're growing, you can see that a little bit sooner. Growth hormone itself is used more extensively in some of the other conditions involving the RAS-MAP kinase cascade, particularly Noonan syndrome. So within the United Kingdom, growth hormone is not licensed for the treatment of Noonan syndrome, but it is licensed for the treatment of Noonan syndrome in the United States. The use has been really quite extensive within the United States. I think perhaps less extensive within the UK and Europe because we don't have that license. It's well shown to be relatively safe and also to increase growth. Quite how much it increases growth is difficult to say because we don't have sufficient numbers of patients treated all the way through to end of growth. There are some benefits beyond growth, particularly around muscle and fat. So particularly if children are overweight, then giving growth hormone can help with that. It can also help strengthen muscle, and in young children who are growth hormone deficient and whom we treat, we can often see an improvement in their motor development, motor skills after having started therapy. And there can also be a general improvement in quality of life. So even sometimes where I see no improvement in height at all, parents can come back to us and say, actually I can see a big difference in how my child is. And in those circumstances, we continue with treatment even if there isn't an improvement in height. So looking at the other side of why might you not want to treat, well, the use in Costello syndrome is actually quite anecdotal. So we don't have a large cohort of patients who've been treated all the way through to final height to show that there is benefit, and there aren't large studies proving that benefit of those other things that I mentioned around muscles and general quality of life. So we need to balance that risk-benefit ratio for the individual patient. I don't know that we're going to get anytime soon large amounts of data on final height, but actually that would be something perhaps very useful that the patient community could help us collect, because we're going to need large numbers.
Lisa?
I'm so frustrated all the time because for our kids, everyone talks about final height. And I think we're much more concerned about the motor development skills and the vitality. And is there more research on that we could actually, because every time we bring this up to, tell the parents to ask, they say, yes, but there's no evidence, like Dr. Stevenson said, there's no evidence that the muscle piece is related to the growth hormone directly.
So what we really need there is an actual, it would be a quicker study to do, but you can do all sorts of studies using grip strength and jumping plate mechanism to really study, and whether if you looked before and after 3 to 6 months worth of growth hormone treatment, and you look at jumping plate mechanism or grip strength, you can certainly measure the muscle aspect, and there are quality of life scores out there that we can use in childhood to really look to see, can we quantify whether there's any improvement, and I think that's the sort of evidence that we would need if we're going to push and say to bodies like in the UK it would be the National Institute for Clinical Excellence to say, can we have this as a recognised indication for giving growth hormone treatment? And that makes it a lot easier for us. Growth hormone is an expensive drug. We're probably talking about £7,500 to £10,000 a year. And I know locally within Manchester, if there's any child that I want to give growth hormone to, I can by and large give it to anyone that I want, but that isn't true across the rest of the United Kingdom, where in some areas, if you don't meet one of the specified licenses, then quite simply the local authority are not going to pay for that treatment.
Can I ask a question to both of you?
Can't hear you. Bring it up.
Question for both of them. In relation to giving the growth hormone, is that currently used only for people with documented growth hormone deficiency, or has it ever been tried in kids who don't have growth hormone deficiency to see if they benefit anyway?
In the US, it's too expensive. They really want to see the deficiency.
Personally, I haven't treated anyone who wasn't growth hormone deficient, but I wouldn't see that as an absolute barrier to treatment. And I would be able, if I wanted to, as I said, don't tell anyone outside the room, but no one scrutinises what growth hormone I give, other than my colleagues. And if my colleagues say yes, it goes through absolutely fine. But there are always going to be low numbers. What we know is that if you have low growth hormone levels, you are going to do better on treatment, almost certainly, than someone who has normal growth hormone levels. And the way we adjust treatment is by looking at that IGF-1 level, which broadly reflects how much growth hormone you've got. And if you start out with a low level, there's scope for me to give you quite a good going dose, and then we're going to get more benefit. Whereas if you start out with a very high level of IGF-1, then there's not much scope for me to give you growth hormone, otherwise I'm going to make it too high. And making it too high goes back to something else we want to mention, which is about the relationship, or the supposed relationship between growth hormone and tumour risk. And there's been a lot of worry that growth hormone as an agent is associated with an increased risk of tumour occurrence. And I think if you look at data in animals, then that is true. If you look at data in humans, then it quite simply is not true. So looking at patients, 20,000 patients treated across Europe, there really is no excess of tumours in patients treated with recombinant human growth hormone. We have very good safety data from Noonan syndrome, another condition in which there's an increased tumour risk, but we obviously don't have very extensive follow-up data in patients with Costello syndrome treated with growth hormone. And what we would need to really quantify if there's an effect is you need a group treated and a group not treated with the growth hormone, and that's difficult to get.
Can I ask just a practical question? So my son, Samson, who is 10, we're in that first year that you talked about where we started it and we're having a trial to see whether it's deemed successful. And so far things are looking quite good, but he absolutely hates it. So he knows that at the end of this year, if he hasn't met whatever the criteria are that have been set, that he can stop. What he wants to know is if he has met those criteria, how long does he have to go on taking it for?
So if you feel there are benefits beyond height,
Yeah.
then what I would say is I think for those you need to take it long term. I think if you stop it, things go back to where they were before.
So beyond the end of puberty, long term, into adulthood.
I would go to end of childhood. If you're taking it just for height, and you've got yourself somewhere up the chart, and you hate taking it, there was the possibility that you can stop, and sometimes you will drift back down, but sometimes you can boost yourself up the chart, you can stop it, and then you'll continue on. I wouldn't stop any time before end of growth, so end of puberty, into a child who was growth hormone deficient. And a child who was not growth hormone deficient, whom I was treating, if they'd gone up the chart, we were just using it to improve height, and then they wanted to stop, then that would be okay to trial stopping for me. You try stopping, if you fall off, you restart. On the subject of hating it, there is, I think, some prospect that we can make things a bit better because long-acting growth hormone is on the horizon. So we're currently starting trials with long-acting growth hormone, which is a once-weekly injection. So if your son is 1, then I would be pretty confident at some point in the next 5 years, we're going to have licensed long-acting growth hormone to give it once a day, once a week, rather than every night. But at the moment, it's just in the trial stages. But it's fairly, it's at the last trial stages before this is licensed for general use.
So my child Annie, she's 3. She was tested for growth hormone deficiency, and it came back because she's not deficient. Would you recommend looking into other reasons then why she's so small, or is it just, do you just accept that she's just small and that there isn't, do you know, like, is there anything else that we should be worried about?
Can you say how tall she is for age 3?
Oh God, she's about 77 centimetres. Yeah. 77, yeah.
So I think it's really important when we see, as a clinician, when I see anyone with short stature, if they walk into my consulting room and they are short and they have, you come into me with an obvious cause of why you're short, we shouldn't assume that that is the entire problem. Because just because you have Costello syndrome does not mean that you might have also developed an underactive thyroid. It doesn't mean you might have any number of other common problems, for example, like celiac disease, that may be causing a child to be short. And so there are a kind of usual raft of investigations that I would do for any child with short stature. And I think it's important that all of those are done. So mostly for me, it's a simple blood draw, one blood test that I might do half a dozen tests on, including things like thyroid,
She's done the thyroid,
celiac screen, your blood count, your kidney function.
She's had all that, yeah.
I do an X-ray to look at the bone age, because if the bone age is delayed a bit, then you can be kind of reassured that maybe height-wise things aren't going to be quite so bad. And obviously, we would also do, there's other standard genetic tests, one particular called a karyotype, that for any girl who's short, that we would make sure was done.
Can we come and see you?
I'm in Manchester Children's Hospitals myself, and the man who really does sees most of our patients with Costello syndrome is Peter Clayton. But he's currently away in China doing a talk in China, so I'm the slightly more junior replacement to him. So the last things we have to think about are cardiac problems. I have to say, unless it's very severe cardiac problems, I don't really worry about growth hormone and cardiac status. And lastly, glucose problems. And again, most of the problems we tend to see in early life are low blood sugars, and if anything, growth hormone is going to make those better. You do have to think about the burden of treatment, and that burden is, at the moment, is daily injections. There's one device that you can use where they can give growth hormone without it being injections. It's needle-free, but it's not pain-free, so it's a bit like being pinged with an elastic band, but it injects the growth hormone with a puff of air rather than a needle. The only time I find it good is for children who are very frightened of needles, but otherwise it's not as good as the needle devices. So in terms of our strategy for managing growth, well, you need to see a paediatric endocrinologist. We need accurate serial measurements of your growth, looking to see is your growth velocity normal, so how fast you're growing. We look to assess your growth hormone status, and then we consider a trial of treatment with recombinant human growth hormone. And I think it's important before you start to decide upon what your criteria, and that's something to negotiate perhaps with your doctor, what are our criteria going to be for continuing in terms of the response that you see. Because you don't want to do 10 years of treatment with injections every night unless you are clearly seeing some form of benefit, either in height or in those other aspects.
As you see, I mean, Helene is just over 4 foot tall. It's not done a huge amount for her height. But Peter Clayton wanted to have a little stop for 6 weeks to do the test, which is fine. But we know by the end of that 6 weeks, she will drop off with energy, she'll become more lethargic, she just goes downhill after about a week of stopping the growth hormone. So we've put it off till next year, because it's something that we dread, because we know how much it affects her. What's that, in saying that, Helene's range was about 2.53 when she last had it done. As Peter was surprised. What is the range of the number where you start giving growth hormone?
So it's actually, the number in the UK, it's fairly standardised to a level of 7 on the test. And everyone who gets a diagnosis of growth hormone deficiency will normally have 2 tests. And we know that if you test the perfectly healthy population, 20% of those normal people will test positive for having growth hormone deficiency. So our tests are in fact a bit rubbish. Now, if you've got more than 7, most people would say it's normal. In other countries, they will still use a level more than 10. If you go to South America, they'll use a level more than 4 as being normal. So the entire paediatric endocrine community can't agree on what represents normality. The one thing I would say is that if it's less than 3, everyone in the world has agreed that that is abnormal and represents growth hormone deficiency. The last comment worth making is, if I was in an area where they were limiting me to how easy it was to use growth hormone, sometimes I would then not do 2 tests. I'll do a single test, call that growth hormone deficiency, even if I'm not personally convinced it really is growth hormone deficiency, but it can sometimes give me that excuse to use the treatment and try it to see if it has any benefit. So the next bit is to move on just to talk a little bit about puberty. So normal puberty for boys, average is 12, and the range is really 9 up to about 14. Anything more than 14 is delayed. For girls, puberty normally would not start before the age of 8 and should be starting before about the age of 13. The first stage of puberty in girls is the development of breast tissue, so quite easy to see. The first stage of puberty in boys is the development of an increase in testicular size. We use this set of beads in clinic. All the children seem to want to play with them, which is a very bad idea, because those are the beads that we use to measure testicle size. Lots of boys these days are very embarrassed about having the testicle size measured, although we know that men actually are not very accurate at all when they self-measure the testicle size. There was a national study that was done in the UK, and I said puberty should start at 9 in boys. 20% of boys rated their testicles as having enlarged puberty size at the age of 7. So from very early on, people do exaggerate.
We noticed for a while before the Costello and CFC mutations, looked like a number of children, boys, were diagnosed with precocious puberty. And then it turned out with the gene test that I think 4 of the 5 of them had CFC syndrome. Have you heard? We know about delay, but not precocious. Did you know about that?
No.
We have seen it
Yeah.
in both,
Yeah.
but it's rare. But it's, I haven't seen it in a girl.
No. Yeah.
It's,
And
we've seen it in one girl.
So commonly, obviously with girls you tend to notice quite easily. With boys, you might see a significant change in behaviour. You get changes in behaviour in girls as well, obviously, indicating an early onset of puberty. The brain sends out these signals from tell the pituitary gland in the brain to make the hormones LH and FSH, which then activate the ovary, and that produces all the hormones that take you through puberty. There's a similar sort of system in boys, and again, it's the pituitary sending out signals to tell the testes to make testosterone that stimulates the start of puberty. And on our set of beads, it's when you get to a size of 4 millimetres that we would say that puberty has in fact started. As I said, the time of onset is normally about 11 to 12. If you're early in puberty, at precocious puberty, then again there are some good medications that we can use to stop that. The main medications people will use are GnRH analog treatments. There are a number of different names for those. The common one that we use is Zoladex, other names are triptorelin or leuprorelin, and those are medications which are injected once every 3 months. So it's a relatively infrequent injection and a very effective therapy. For children who go through an early puberty, one of the big worries, if you go into puberty early, are you going to end up being shorter because your puberty has started earlier? I think for most children with Costello syndrome, where we know there's a tendency for height problems, if you go into puberty early, I think we would be saying that we ought to go ahead and do some treatment to stop it. The data on using this treatment to improve height, it clearly shows that if you start with puberty before 6, it will make you taller. It's less certain if you start treatment after 6. But if I saw someone who already had another condition leading to height impairment, I would in fact want to start pretty early on. The other advantage to suppressing puberty if it starts early is that usually you reach periods sometime between 2 and 3 years after the start of puberty. So if you go in earlier, then many families will want to stop those early periods. Delayed puberty is probably more common. Certainly for boys, more than 14 or 15 years would represent a delayed puberty, and for girls, more than 13 years. Delayed puberty is relatively easy to treat. In boys, you give injections of testosterone to kickstart puberty, and that's an injection which is usually around once a month. For girls, we give them treatment with estrogen, and estrogen is currently given in the UK as small patches. It's the HRT patches that we use now. We used to use tablets, but there was one manufacturer of the tablets who was charging £25,000 a year for a course of estrogen tablets, and the HRT patches cost 75 pence a month. So we've largely moved over onto using patches, although for those children that can't cope with having a small patch, it's just like a plaster, then they can still have the treatment with pills. So that's just what I said. Precocious puberty is less than 8 in girls, less than 9 in boys. And we've talked a bit about both using treatment so sometimes with delayed puberty, you just give a short course of treatment and that will kick-start things. Other times it will take a longer course of treatment, perhaps 1 or 2 years of treatment, or even ongoing treatment throughout adult life. To move on in our last 10 minutes, the hypoglycemia, a problem we've seen more, actually recognising I think more commonly in the Ras-Raf-MAP kinase disorders generally, and hypoglycemia refers to low blood sugar levels. And this is a problem we would more commonly see early on in life. So very non-specific symptoms, things like shaking, sweating, anxiousness, dizziness. Typically it will be the symptoms that are almost immediately relieved by eating something. Because obviously eating something sugary will restore the blood sugar levels. the pancreas gland, which sits in the stomach, that makes a hormone called insulin. So when you eat, the sugar goes from your stomach into your bowel, into the blood. The pancreas senses how much sugar there is, and it releases the right amount of insulin to control your sugar levels. And sugar levels too high will give you diabetes. If you actually have a bit of overgrowth, so too much insulin being made in the pancreas, then even when you're not eating, the pancreas makes too much insulin, and that causes your blood sugar levels to drop. And that's the situation which we've seen. We've seen it mostly in young babies, and in fact, we can normally manage that with if needed with a very relatively small dose of medication. So this has been reported in patients with Costello syndrome. If any children have gastrostomies or are nasogastrically tube fed, then the other situation we sometimes see is children who get dumping syndrome. And dumping syndrome is very much like what it sounds. So you take food, it goes into your stomach, and then rather than being coming out relatively slowly into the gut, if it's all dumped at once, we get a spike up in the sugar levels. The insulin levels spike up because you get this big rise in sugar, and then your sugar levels actually get brought down too far. So it's important to distinguish between too much insulin because the pancreas is a bit too big, and dumping syndrome where you're just letting out the food a bit too fast. So if it's dumping syndrome, then we can change that by using different types of meals, so less faster acting carbohydrate and less fluid with the meals. That can often help, so no treatment, so no medication needed. If you've got blood sugar levels which are low because of too much insulin, very rarely we might have to use a medication called diazoxide, which turns off insulin production. Diazoxide is generally a very safe medication, but if you have pre-existing heart problems, then that would be something that we would be a little bit more worried about. The main side effect we see with diazoxide medication is actually the child developing a little bit too much hair. So particularly people get more worried about that in girls. So the other most important thing about low blood sugars is that there's a critical window in which we've got to make that diagnosis, and we must get blood samples taken at the time at which the blood sugar levels are low. So if you ever have a child with a low blood sugar level that's got better and someone wants to take a blood test, it's almost certainly going to be pretty pointless. So I think that's, if you see, particularly in babies and young children, unexplained episodes of sweatiness, irritability, then do think about low blood sugar levels. It's a very easy thing to test for. And those are, we may need either that diazoxide medication or to change the diet slightly. Lastly, because we've only got a few minutes left, I'll talk about calcium. And we have seen problems with too much calcium in the blood. The calcium is actually regulated by glands which sit up in the neck. So you've got this big gland that you'll have heard of, I'm sure, called the thyroid gland, which sits in the neck. And embedded into that are 4 tiny glands called the parathyroid glands. And they largely control the body's calcium levels. And they control the calcium levels by telling the gut to absorb more calcium and and it can tell the bones to release calcium. So your skeleton is actually a very good source of calcium to keep the blood levels up. The main problem we've seen has been high blood calcium levels. So the symptoms again can be quite vague: headache, irritability, confusion, thirst. So in young children you tend to see very much difficulties with growth and drinking lots and passing lots of urine as well, and nausea and vomiting, other symptoms. In older children they can have very poor appetite. The main cause of this has been overgrowth of one of the parathyroid glands. So in terms of what we do, if you see any of those symptoms, we should have a blood calcium level checked. And if we do find that the cause is an overgrowth of a parathyroid gland, it's a very easy thing to fix. A simple operation to take it out will actually fix the problem. The main thing you need is, if you have a high calcium level, you need to see not only an endocrinologist, but an endocrinologist who specialises in bone and calcium levels, because that doesn't represent all of this. So in summary, we see lots of slow growth. We do see hypoglycemia. Hypoglycemia is mainly in babies or in early childhood, and again that can be caused by high insulin, dumping syndrome, or even growth hormone deficiency. We often see delayed puberty, but more rarely precocious puberty, and both of those are very easily treated. and we can see problems with high calcium levels. Down at the bottom there we mentioned high prolactin and low cortisol levels, but so far those have only been reported in a single child. So thank you very much for your attention.
Ask lots of questions, I'll get exercise.
Thanks, Phil. That was a really nice, clear presentation, even for the geneticists to understand, I think. So that's good work. I'm wondering about some of our adult patients with Costello and CFC syndromes have an absence of periods and have never had menarche or had one period and then never again. And that undoubtedly causes quite a lot of concern, although I think it's sometimes balanced with it's less of a burden. But the issue of bone protection, it's not quite so much a paediatric question, I know, but I guess you follow people into adulthood who might have extra needs in that way.
So the first caveat we've got is the best thing to do is obviously to say, can we measure bone density? And it's perfectly possible to measure bone density, but the adult bone density reference ranges don't automatically correct for height. So if you've got someone who is short, then actually you do a bone density scan and their bones are normal for the size of their body, but they are not normal if you compare them to the average statured adult, which is what they do in most adult practice. So there is actually calculations that you can do that we run in paediatrics that could be applied to see is the bone density actually low. The second and I think more important question is, have you had any fractures? So if you've had fractures, particularly what we refer to as fragility fractures, where you've broken a bone in a scenario when you should not have broken a bone, so minimal trauma, things like falling off a couch, if you break it then that says there was definitely a problem with bone minimum density. So even beyond having a scan, if you're seeing that problem, then we give some treatment for that. And where you're thinking about periods, well, we can quite simply measure estradiol in the blood. And if you have very low estradiol levels, then we can actually replace your estrogen without giving you periods. So there are preparations of hormone replacement therapy which will restore you to normal estrogen levels, protect your bones, and you will not, and the patients will not have periods, so we can avoid that issue.
Right over there, we need more exercise.
Hi, thank you. That was a very good presentation. My question is about administering growth hormone. So my child is 8.5 and she is CFC, and we've just gotten approval. She doesn't have a deficiency, but on the charts, she is below the 0.2 percentile. We've just chosen the puff of air pen just because the idea of putting needles into her every day was more upsetting to mommy than it was. But I'm concerned about what you just said. So can you just elaborate on that a bit? Is she going to still get a good administration, or is it just...
So if you're on a dose less than 1 milligram, our experience is that you will still get a reasonable administration. If you're on doses more than 1 milligram, then the thing to check is whether there's any wetness left in the skin after you've administered it.
Okay.
And so typically what we've seen is that when you use those higher doses, that in fact some of it isn't getting through the skin. But if you're using doses under 1 milligram, then most of that will be going in, and that's not too much of a problem. But if you're not growing it, and not seeing effect, and your physician wants to use higher doses, then that's the time to think about potentially changing. But if you've only just started, then maybe...
We haven't even started yet, we just picked the pen.
Maybe in 2 years, maybe in a couple of years' time, we'll have that long-acting once-weekly growth hormone available to help with that.
Which would be great. Thank you so much.
Anybody else? Right, thank you very much indeed.